Okay. All right. Welcome, everyone. And thank you for joining us for the Lurie Children's Community Provider Symposium. I'm Chad Worley, and I am thrilled to welcome you today. I am joined by my colleagues, Paula Nowak and Julie Kalkbrenner. We're excited to have you, our community providers, our practice managers, and referral coordinators. In this ever-changing landscape of pediatric healthcare, we recognize the vital role you play on the front lines of care for children and families. This is why we have curated a great agenda packed with the latest updates and information to empower you in your work. Whether you're navigating the complexities of infectious diseases, embracing the opportunities of telehealth, or seeking to understand the evolving resources available here at Lurie Children's, we've got you covered today. First up will be Dr. Ravi Jhaveri, our division head of Pediatric Infectious Diseases. He will deliver a timely and crucial update on COVID-19, the flu, and RSV as we head into the colder months. Next, as we've all experienced, telehealth has revolutionized the way we deliver care. Bridget Hillman, our manager of Telehealth Operations, will share the latest developments and the best practices in this rapidly evolving field, equipping you to make the most of this powerful tool. Following that, Carrie Alden, our Vice President and Chief of Ambulatory and Advanced Practice, will take us on a tour of our exciting outpatient center space reallocation project. She will also give you the inside scoop on our brand new outpatient centers in Schaumburg and Austin, and we'll give you the developments that will enhance the care of the experience for your patients. Close out our presentation, Paula, Julie, and I will introduce you to the talented new specialists who have joined Lurie Children throughout the year. We're expanding our services in ways that will undoubtedly benefit the families you serve. And you'll also get an update of some programs and services we're particularly excited about that we think you will be too. But before we dive in, just a reminder, for a smooth virtual meeting, we're going to keep the lines muted to minimize any background noise. If you have questions, and we do encourage questions, please don't hesitate to put them in the chat box. We'll address them to the best of our ability. But of course, we built in time after each session for a Q&A after each presentation. So come ready with your thoughts and queries. Lurie Children's, we are proud to announce that we're ranked number one children's hospital in Illinois by U.S. News and World Report, and we once again have achieved honors as their best children's hospital rankings with 2 specialties in the top 10 and 5 in the top 20. This, along with the Newsweek as one of the best specialized hospitals in pediatrics and number 1 in pediatric cardiology and cardiac surgery, demonstrates our commitment to excellence and the trust families place in us. But with that, it's my pleasure to introduce our first speaker, Dr. Ravi Jhaveri, Division Head of Pediatric Infectious Diseases. Dr. Jhaveri, thank you for joining us again. We're eager to benefit from your experience.
Thanks, Chad. Thanks to all of you for being here. Hopefully you can hear me okay. I just thought I would give you a brief respiratory virus update and then answer any questions you have about these topics. So next slide. These are just some disclosures I highlighted in yellow, the ones that are relevant to the respiratory viruses we're going to cover. Next slide. All right, so I'm going to offer you a couple of predictions for the upcoming flu season, review the latest about RSV circulation and prevention data, and then we're going to talk a little bit about the most recent COVID-19 boosters. Next slide. All right, so just highlighting our current flu vaccine options for this season. Next slide.
Sorry.
That's okay.
My bad.
No problem.
How's that?
Okay, so no problem. Thanks. So these are all the pediatric vaccines available. You'll see the top panel are all the injectables and include the egg-based versions, as well as the one cell culture-based version, that Flucelvax in the middle, all licensed down to 6 months. And then we still have the live attenuated vaccine, which is the intranasal option FluMist. that is also an egg-based vaccine. It's really important to just remember that for this season, after there was not any flu B from the Yamagata family, we now have gone back from the quadrivalent versions of flu vaccine that we used to have, to just the sort of old version, which is the trivalent, which is an H1N1, H3N2, and a B Victoria strain. Okay? And so those are the components of all of the current vaccines now. All right, so here are my predictions. This is a photo I took over the lake when we had that supermoon a couple months ago. That's probably the best picture I've ever taken on my phone. Go ahead. All right, so we tend to use Southern Hemisphere data to offer us some insights into what we have to expect. So this is data from the South American countries over this past summer, which was their winter, okay? And they had a flu season that when the flu isolates were broken down, they had about 2/3 that were H3N2, 1/3 that was H1N1, the pandemic 2009 strain, which is really the only H1N1 we see, and then just a sliver of cases of flu B. And then when they looked at the performance of their flu vaccine over their season, it was on the low end for the season. So if you look at I didn't want to overwhelm you with the numbers, but if you go through the young children data, for instance, you'll see that the range is anywhere from a low of 38% to a high of efficacy of around 67%. And that has to do with the fact that in general, flu vaccines work better against H1N1 strains than they do H3N2. And there's so few B strains that there's no predictive efficacy numbers there. Okay, so next slide. So what I would say is that if you look at some of the data, we're likely to have a pretty active flu season this year. I suspect it will be similar to what was seen on the Southern Hemisphere, which is predominantly an H3N2 year. Which means that our flu vaccine is probably not going to be on the high end of its performance range. I think many of you in practice appreciate that fewer people are getting vaccinated. And whether that's just because of COVID fatigue, misinformation, general anxiety and vax hesitancy, I think it's all of the above. I think many of you have told me that it's just become more difficult for you to provide vaccine in your own offices. And so many of you have also offloaded some of the demand to commercial pharmacies, which some people appreciate and other people find challenging. And so I think it's just changed our behaviors in a way that we just need to be aware that our numbers are likely to be lower when it comes to those vaccinated. Next slide. So what can you do? So obviously the most important thing that you guys can do is continue to preach the benefits of flu vaccination, certainly emphasize and give people the context that the protection against severe disease is much higher than these vaccine efficacy estimates. And so just because people get infected, if they get a mild case of the flu and don't need to seek medical attention, don't have to be hospitalized, these are all really important outcomes. And the discussion is very much like the COVID discussion, okay? If you have the opportunity to vaccinate, take every opportunity, don't delay. Really try to seize the moment. And I would just also encourage you that if you do have other versions in your office, there may be some appeal to some of the other versions that are out there, whether it's the cell-based vaccine, the intranasal vaccine. Compared to the injectable egg version that probably many of you use. Okay, so that's the flu part. So let's talk about RSV. So this is where we are currently. This is hot off the presses earlier this week from the RSV surveillance that the CDC publishes. We're still pretty early in the flu season this year. You'll see that the states in sort of the lighter blue are where things are really starting to take off. This is not unusual. Florida actually very consistently is usually the earliest part of the RSV season. And for reasons that we don't totally understand, it starts in sort of that southeast region of the country and then moves north and west to gradually cover the rest of the US over the course of our winter season. So this is, I can't explain Ohio. My guess is it's probably just very low numbers with a few positives that have skewed the map, but there's no reason why Ohio should have more than 10% positive. It's probably like 11 isolates and there's one that's positive, and that's why it's, or 9 isolates, I should say. Anyway, next slide. So one of the things that I think is really exciting that the group of us was just talking before we opened up the doors for all of you was that it's really exciting to see that the monoclonal antibody nirsevimab seems to be working really, really well. These are some data that were published based on the experience last year with even partial uptake, showing that approximately 90% effectiveness in one of the CDC-funded networks against RSV hospitalization in young infants, okay? And I just came back from the Infectious Disease National Meeting last week. There have been many papers published over the last few months, and then a slew of presentations last week, just showing that this is now a consistent observation across many sites in our country, as well as many locations across the globe. Really very impressive effectiveness, okay? So this product and then subsequent products coming, whether it's other maternal vaccines and other monoclonals, are likely to completely change the game for RSV here. Next slide. So what does this mean for you? So again, continue to share this positive experience of RSV prevention and certainly try to counter any misinformation that may be out there. I'm not aware about specifics, but I'm sure someone's going to make up a slanderous story about this monoclonal antibody. So be ready and armed for that. Certainly, depending on what systems you're most closely affiliated with, whether it's our Lurie system or other partner systems or other systems, try to confirm receipt in the nursery prior to discharge. And then obviously in your own workflows, making nirsevimab available in your office. And this is particularly important for those young children with risk factors that go into their second season, where they're going to be really relying on you in the office to be administering that dose during the second season, okay? And certainly also discuss the other options that might include maternal vaccination. There may be certain families that prefer that option, find it more convenient for whatever reason. And at this point, all the data is suggesting that all options are equal. Okay, next slide. All right, let's spend a moment just talking about COVID-19 and the updated boosters. Okay, so many of you are familiar that the FDA approved now the updated versions, which are now the next gen, current contemporary Omicron isolates that are out there. The Moderna and Pfizer mRNA vaccines have these KP2 isolates, and then actually the Novavax protein version, which is approved down for use to kids 12 and older, uses the related JN1 strain. So it's related, but just a little bit differently, okay? And you can use any of these versions for the primary series or booster series, depending on who's received what or if they haven't received anything. Next slide. You guys all know this, but again, I feel the need to, again, point out that we are still seeing SARS-CoV-2 out there. We still see hospitalizations, particularly in the youngest kids. They are the most vulnerable, and the older kids at this point now represent the lowest line, but also just keep in mind that's a big denominator, so the rates will be lower just because of the larger number of kids in that age group. Okay, so it's not zero, but it's certainly still rate-wise lower. Next slide. And I think you all have a sense that we really have made no progress at all when it comes to vaccinating children. Our rates have been pretty much flat for this whole last year. I mistyped that. We've only reached 20%. We have still not reached 80% of the youngest kids. And I certainly recognize that we are sort of in this state of perpetual COVID fatigue where nobody even wants to talk about COVID anymore, even though many people are getting it, many people are infected, missing school, missing work. So it's still out there. Next slide. So again, I think what can you do? Please remind people that COVID is still a thing that we have to worry about. Continue to discuss the safety and benefit for young children, the fact that there is a much higher risk that they may be hospitalized. And certainly if they have risk factors, stress even more the potential benefit for them. And then I think really reframe the conversation and also just talk about the fact that there's still lots of missed school and missed work. And even here at the hospital, I can tell you this summer, I mean, more than half of the team members missed a day or more of work, whether it was because of their own illness or because of a child's illness. And so it's still taking a toll on all of us. And so thankfully, people aren't dying, but at least not our pediatric patients are not dying. But this is still a challenge. And so there's still a lot of benefit to be gained by having these vaccines and conducting these vaccine discussions. Okay. All right. I've got thank you very much for joining. I've got a few minutes for questions.
Thank you, Dr. Jhaveri. Appreciate it. While we let people type up any questions they may have. One question I had for you is with the recent natural disasters on the East Coast that happened, I know that was a shortage in a lot of vaccines and IV fluids and stuff like that. Has that affected us here at Lurie or this general region? And can you expand on that a little bit?
Yeah, sure. So many of you, I see my camera's flickering a little bit. Sorry about that.
No worries.
If I may just turn it off, but I'm still here.
You look like a cartoon, which is fun.
Yes, yeah, which is right. My kids would enjoy that. So as Chad is alluding to, Hurricane Helene specifically really devastated the Southeast, in particular North Carolina, where one of the largest IV fluid manufacturers has their primary base. And so that's really disrupted our supply. So we have tried to be preemptive about advising our health providers and our health systems about the extent and nature of the IV fluids. We've tried to pivot as much as possible when non-IV options are acceptable. And obviously, in emergency situations, we still have the fluids that are needed to, resuscitate patients in the ED or in the ICUs. But we've really tried to pivot whenever possible. I think people are optimistic that our supply will perhaps come back a little sooner. But still, we don't want to get complacent about this. So this is still very much top of mind, and our team is working very closely with our CMO's team about making sure that our guidance is up to date and reflects our current availability. Okay.
Okay. Thank you for that.
Sure.
So,
thanks for the question.
I got a couple here in the chat room.
Sure.
Dr. Bauer, how are you? Good to see you. He asked, is there a preference for maternal RSV vax versus post-birth nursefamab? I'm sorry, I don't know that word.
That's
sorry.
Okay. No, you actually did pretty well. So I'm sure there's a preference from a patient and perhaps even provider standpoint. If you look based strictly on efficacy against the most important outcomes, there's really not major differences. And so I think there's not a clear, like, this one is better than the other version. They're mostly in that high 70s to low 90s% when it comes to RSV hospitalization. And it's very likely that once we have multiple options that we may be using sort of options sequentially. But at this point, I would say if a family or a patient has a really strong preference for one or the other, I would go with that. Again, whatever is easiest and timely for them to get to protect them during the season is the best option.
Okay, thank you. Another question, Stephanie Meckner says, we've been seeing a lot more pertussis in the community and our testing has been slow to come back. Would you be able to speak to some strategies for addressing the outbreak for community pediatricians?
Yeah, sure. So thank you for the question. Pertussis, as many of you know, is a persistent bacterial infection. We had done very well with really rigorous vaccination of not only infants, but also adults and pregnant patients with each pregnancy. One of the sequelae of COVID, obviously, you all appreciate, is drops in vaccination rates, which has driven some national pertussis outbreaks. So when we think about pertussis, I think it's really important to keep in mind the idea that we tend to think about pertussis as prolonged cough, but many viral infections can also lead to prolonged cough. Okay, so pertussis is not the only one on the list. So I want to stress while you're waiting for testing, it's not necessary that you should be prescribing antibiotics for all your patients. However, what I would say is if you do the viral testing and it comes back negative for a patient who's had a cough for several days, then I think perhaps it's worth starting to consider the likelihood that this might be pertussis. You can enlist the help of certainly our system for some of the molecular tests for pertussis that do come back fairly quickly. And so that may be another option. It's part of the respiratory panel of testing, and depending on whether the patient is being seen within the first, I think 2 weeks or so of illness, that testing should be fairly reliable. So I hope that helps a little bit.
Okay, thank you. And
Sure.
then we have one last question. It's a two-parter from Tara
Sure.
Brito. She's asking about Beyfortus. So, and your thoughts on infants who already tested positive this season but are less than 8 months. And then the other part was giving Beyfortus to infants whose moms got Abrevzo. Sorry, in January,
sure. So,
February.
Yeah.
I don't know if you could see that, but yeah.
Yeah, I can, but I've followed it. So the big picture question, Dr. Brito was using the brand names for the nirsevimab infant monoclonal and the maternal vaccine. So the two-part question. So the first question is, what benefit would there be for giving the monoclonal if a patient's already tested positive? I think that's still fairly an unknown. Because we are advising universal administration, I think I would err on the side of still giving it, particularly if the infant is young and we're at the start of the season. But I will admit that I don't think there's a caveat, but also I think the N of this scenario may be low enough that they haven't yet revised the guidance. So I think I would err on the side of still giving it if the infant is eligible. Your question about whether there is tangible benefit to giving maternal vaccine plus nirsevimab, at this point, it's still an either or. If you've got one, then that's probably good enough. The maternal antibody should last long enough during this season to cover you. Some of the real world studies that were presented at the meeting last week did show that some infants, a small percentage, are getting both. That may be due to lack of tracking. That may be due to a provider discussion. It's not clear that 2 is better than 1 at this point. And so I think if you can confirm that the parent was vaccinated during pregnancy, then I don't think you need to do the guidances that you do not need to administer the nirsevimab. If there was not maternal vaccination, then you should, whether it's in the nursery or in those early visits in your office at the start of the season.
Okay. And I know you got to jump to another meeting, but there's one quick one. Look like pertussis set off another question. If you're waiting for results for pertussis, should they go to school or should they isolate for 5 days?
So there is the possibility that they could still be infectious. I'm not sure what the official guidance is. I would suggest that they could go to school and wear a mask. I know that's a very not popular thing to say, but I think that that's medically appropriate and would contain the risk. So that would be my advice. Stay in school, wear a mask. Okay.
Stay in school, wear a mask. You got it.
Yes.
All right.
All right.
I'll tell my kids that when I do that to them, and I'll say it's your fault. Okay?
Please do. Yes. No problem. All right.
Thank you for joining us. Have a great day. We'll talk to you soon.
Take care.
All right. Bye-bye. All right. I got to thank everybody for all those questions because the questions that you ask really help make this program because though someone who's listening to the audience may not be thinking about those questions, if you do, it may spur them to think about something that they have. So please don't be shy to ask more questions for us. But thank you, Dr. Jhaveri. And now we're going to go ahead and we're going to transition over to Bridget Hillman, our Manager of Telemedicine Operations. Bridget, welcome and thank you for joining us today.
Thank you. Good afternoon, everyone. I'm here today to talk about telemedicine and digital health. So like it was mentioned, I'm the manager of Telehealth Operations, but I sit within our within our digital health team. So if you can go to the next slide, I want to start by framing our digital health department, since we've evolved over the last several years. So telehealth is one of the three main pillars of our digital health program. And all three of these areas are anchored by clinician efficiency and patient experience. So our digital front door is focused on engaging patients across multiple channels. So that would be our website, actually how patients schedule appointments with online scheduling, texting, those appointment reminders, bidirectional texting, and phone, and then enabling self-scheduling, patient access resources through MyChart, and just online schedule in general, and then improving patient and family satisfaction with the longitudinal care experience. And then we have telehealth, which our focuses there are implementing and integrating a telemedicine platform for consistent experience. So about 2.5 years ago, we introduced a new telemedicine platform. We've been live with that for a while, but it's integrated within our Epic system. So that's improved our patient experience a ton. Increased opportunities for peer-to-peer consultations. So not only do we use Epic Video Client for our ambulatory visits, but we do use the telemedicine platforms to connect with other providers or other hospitals for various reasons, as well as in the inpatient setting. We use it for connecting our families with patients if they can't be in person. So using iPads and some telemedicine workflows there. And then leveraging telemedicine to improve space utilizations and grow operational capacity. So a lot of times we hear that providers are strapped for space, or there's challenges for patients to get in person. So getting creative with our providers and with our specialists to offer more availability to our patients for those appointment types that would be appropriate in the telemedicine setting. And then our third area under digital health would be remote patient management. So that's focused on creating longitudinal care models to support patients in the asynchronous phases of care. So I'll talk a little bit more about Care Companion, which is the tool within Epic that we spent a lot of time focusing and building in different areas of our organization. But we look at integrating remote monitoring solutions to existing care workflows. So whether that's perioperative workflows, or there's a variety of different areas that we have built a Care Companion to support our patients. But the goal there is to reduce the administrative burden while also improving the experience and quality of care for our patients. All right, and then here is an overview of our digital patient access landscape. So in the last slide, I mentioned that our team has put a lot of focus on improving patient access and experience with our digital tools. So I wanted to include this slide today to show some of the areas that we've spent our efforts. So MyChart activation, MyChart, as I'm sure most of you know, is our patient portal through Epic. And we've spent a lot of time focusing on getting our patients into MyChart so they can use all these tools that we have available for them to improve their experience. And over 80% of our patients are now on MyChart, and about 60% have logged in the last 3 months. So it's not even just getting them signed up for MyChart, it's getting them to actually use the tool. And then online scheduling is a huge focus for us. We want patients to be able to schedule at their convenience through our digital tools. So we're consistently focusing on how we can improve the access there and get as many visit types and specialties available for patients there. The Care Companion pathways that I mentioned in the previous slide too, we have 12 different pathways developed, which is the most of any other pediatric organization. So we're very proud of that. And again, that's in the asynchronous fashion to support different programs when the patients can't be in front of the providers. FastPass is a tool within Epic that just allows patients to be notified if there's any last minute cancellations. So this goes back to that patient access piece where we want to make sure that not only are we getting our provider schedules filled, but also making sure that that patients can access what is available and really maximize how they can get into our providers and reduce those long wait times that they may face. And then for telemedicine optimization or telehealth optimization, which is what I'll spend the majority of the rest of this presentation talking about. We've really focused on improving our telemedicine platform, like I mentioned. So we switched over to a different one a couple of years ago, and we've gotten some great feedback from that. And we also introduced video interpreting services. So we're really focused on not only improving telemedicine, but improving telemedicine for all of our patients and focusing on the equity piece. So we have about 38 different languages available, and the video interpreter can join our platform, which is a huge patient satisfier. And we have evolved care delivery functionalities, and then, like I mentioned, narrowed that digital equity gap. So along with that the video interpreting services, we also have MyChart Spanish available. So patients that are Spanish speaking and have that preference within Epic, their entire experience from start to finish is completed in Spanish. So every appointment reminder, the decision trees or the questions that they're asked while scheduling their appointment, the actual functionality within our telemedicine platform, and the interpreter that joins as well. So that's been great as well. Next slide, please. Okay, so the Lurie Children's telehealth framework. Telehealth and telemedicine are often, they're two terms that are used mostly interchangeably, but at Lurie Children's, we use telehealth as the umbrella, and telemedicine refers to the care delivery. But within telemedicine, we have 3 buckets of telemedicine. So that's real-time, asynchronous, and then remote patient management. Real-time would be your provider to provider visits that everyone's familiar with, where the patient actually schedules. The provider to provider consults, where providers may consult other specialists for input about their patients, or the direct to patient appointments, where that is when the patients schedule their appointments with the provider and you're seeing the patient in a synchronous fashion. Asynchronous, we have provider to provider options available. E-consults are a newer topic. That's something that's in development, but that allows providers to create an encounter within Epic and get those questions answered, rather than having to pick up the phone and make that call. And it's just a much more streamlined workflow. And then the direct to patient asynchronous workflows, those are what we consider, or what we call e-visits. So e-visits within Epic allow patients to talk to their providers about an issue through MyChart messaging. And those are billable encounters as well. And for the appropriate reasons, that can be completed. And it saves the patient and provider time in the office or through a synchronous telemedicine visit. And then remote patient management, like I had mentioned in the last 2 slides, that includes, we have 13 different care plans right now, but that can include wearables, mobile apps, and then patient generated health data. Along with those 3 buckets, we consider the supplementary applications in our framework too. So that's the education, research, public health, and advocacy that telemedicine or that telehealth all falls into. Next slide, please. Okay, so telemedicine allows us to align patient priorities. In the traditional model of care, the patient is at the center, and we do our best to align the right care by the right provider at the right place and in the right time, but it doesn't always line up. So whether the patient can't get an appointment in a timely manner, whether the provider's running late or the patient's running late, it can be on both ends. The patient may need to travel. So I'm sure everyone's aware of those barriers where they may not have reliable transportation. There's costs associated with that. And whether the cost is the actual transportation or missing work, childcare, etc. That creates challenges for patients in certain scenarios, but through telehealth, we do have the opportunity to line these up. So on the right-hand side of the screen, you can see that that's where all these puzzle pieces fit together. So at Lurie Children's, we see just under 50,000 ambulatory telemedicine visits per year. About 80% of those are mental health appointments, and then the other 20 would be our subspecialty care. But one thing that we're focused on is telemedicine really had an uptick about 5 years ago when the pandemic hit, and I think it was well utilized in the following years. But now, 5 years later, we know that it's here to stay. So it's really reframing the conversation with providers and with patients of what can we do to continue to improve this process, or how can we standardize the reasons for care through telemedicine and the comfort for patients and their families to use this tool when appropriate. So like I mentioned, some of that is with our equity work, specifically with our Spanish-speaking patients, and making sure that everything is standard across the board. So making sure that when the provider fills out the follow-up section, that when it is appropriate, that they give the patients, regardless of the language that they speak, the opportunity to follow up in person or telemedicine if telemedicine is appropriate. So there's some work going on with that. And within my chart too, just improving the experience for patients to schedule into both in-person and telemedicine appointments at their fingertips. So not hitting any of those barriers through the scheduling process. Next slide, please. And then one of the programs that we have introduced in the last couple of years is virtual immediate care. So we want to help patients find the best pathway for care. And aside from our ED and in-person immediate cares, in December of 2021, we launched virtual immediate care to give patients another avenue to receive the care that they need, if appropriate, through telemedicine. So this is offered 7 days a week. Our hours range from 12 p.m. to 8:30 p.m. depending on our patient and provider demand. It really looks different depending on flu season and whatever else is happening. But we staff this with a variety of our Lurie children's pediatric providers, and we're seeing close to 1,000 patients a year through this. We've worked through a lot of the different workflows, so we auto forward visit notes to the PCP offices and encourage patients to follow up with their PCPs as needed. But our goal is always to keep patients within their medical home or with their primary care provider. So that's our number one priority always, but having this avenue for them allows patients to see a provider through virtual immediate care if they don't have access or there's no appointments available with their primary care provider. And this is another option for them. In the middle screenshot, you'll see what types of care or what type of care does my child need. This is something that we put together as a handout to assist in educating what the right mode of care is for patients. So really the focus here is to, like I said, educate on what needs to be seen in the ED versus what can be seen in an immediate care, or whether patients should see virtual immediate care or their primary care provider. So this is something that we're constantly pushing to patients just to get them in the right place, both for their own benefit and just to make sure that we can keep our ED waiting room filled with the patients with the higher acuity needs. But along with this handout, we also introduced Symptom Checker in my chart. And that's the same idea where patients have the opportunity to select from a number of different symptoms that they may be experiencing. And it includes some questions for them to answer in order to identify what the appropriate mode of care would be to seek. But like I said, our goal is always to keep them within their medical home.
If I may, a lot of the providers online may have seen the what type of care does my child need flyer. We have distributed that, Paula, Julie, and I, to our providers throughout since it was produced. But for those of you online and who are watching the video, if you'd like a copy of that, we'd be happy to share that to you. So just reach out to your liaison and we can provide that for you.
And we do have that in both English and Spanish too. And then the last slide I have here for today is just a call out for our online scheduling tool. So over the last several months, we've introduced online scheduling for all. And the big takeaway here is that patients do not need a MyChart, and this is new patients too. New patients do not need a MyChart account before scheduling their first appointment with us. So for your patients, if you're referring them to one of our specialists, they could actually go online in your office or while they're waiting for something and schedule that referral in real time there. So we encourage you to encourage them to use this tool at their fingertips, and hopefully that improves their own patient experience there. The one thing I did want to say is there are a select few specialties that do require MyChart appointments, and that's just based on some of the panel scheduling for cardiology and pulmonary. But the majority of our specialties you can schedule right online, and that's in our main website where there is a make an appointment option. And then on the left-hand side, you'll see where it's new patients, and there's a drop-down menu with all the different specialties that they can schedule with. But that is what I had to present for today. So I have some time for questions. And I also have our team's email listed below if anyone would like to reach out.
This was outstanding information. We really, really do appreciate you being out with us today, Bridget. I just received a text message from a practice manager, and it was regarding the Fast Pass that you mentioned. Is that only for Epic? Because a lot of our providers aren't on Epic. So can it be done through Epic Care Link, the Fast Pass?
That's a great question, and I actually don't know the answer, but I can follow up once I talk to my team who would be able to answer that.
That'd be great, and I'd be happy to share that with the audience when I send out the video, and I can answer questions for you all. Tara Brito asked, do Community Connect practices have access to Lurie's telehealth platform through Epic?
Community Connect?
Yes.
Yes, they should.
Yes, that's my understanding too. And then Elma writes, is immediate care available for Medicaid patients enrolled in managed care?
Yes.
They are. Okay. Excellent.
And I did get a question about or I did get an answer about FastPass actually, and it's an internal function, so it wouldn't work with.
It wouldn't work.
Yes. Epic Care.
Okay. As always, if you have questions regarding your appointments, and you can't get a hold of someone through Epic, always contact your liaisons. We could always try to help you too with stuff like that. So, Bridget, I don't see any more questions here for you. So I just want to thank you again for joining us. And then if anything else pops up along the way, I'll be sure to email you and your team. But for those of you online and watch the recording, you see here on your slide, you could also email Bridget and her team at digitalhealth@luriechildrens.org, and they'd be happy to help answer any of your questions. Thank you, Bridget.
Thank you.
Thank you. All right. Hey, Carrie, you are up next. We're excited to have you. You got some stuff going on.
Yes, I do.
A lot of the providers that we work with on a regular basis, Paula, Julie, and I, have been asking us a lot of questions about what's going on with our space reallocation project. So can you tell us a little bit about that before you do? But can you tell us a little bit about yourself and your background here at Lurie?
Sure, absolutely. I'm happy to be here with everyone. I'm Carrie Alden. I'm the new Chief Ambulatory Officer, but I am not new to the institution. I have been here for about 25 years and have practiced clinically the entire time. And so the first portion of my career here, I spent in the cardiac ICU and with the cardiac surgery team as a nurse practitioner. And for the last 13 years, I have been in various leadership roles and have functioned as a nurse practitioner as part of our cardiology department. And that has been in our neurodevelopmental program that I was part of the development of that and have been seeing patients for years in that program, which is all of our high-risk congenital heart defect patients that are at risk for challenges with their development as well as their psychosocial growth. And then I also have a clinic that is a priority access clinic to see patients with murmurs, chest pain, abnormal EKGs as well. And that is an ASAP clinic, which is great for me. I could have no patients one week and I can be completely full the next week. So it's a great clinic to be part of. And in the last couple of years, I was director in the Heart Center, so met a lot of you through my work there, and then moved on to be the chief of our advanced practice providers. And then since the spring, also the chief of ambulatory. So as Chad said, we have a lot of exciting things that are going on in our area. The big things that I'm going to talk about is our new Schaumburg location and our Austin location. And with those new locations, we have done reallocation of our space, and with a focus of really having our surgical services present in our locations that are AASCs or surgery centers, so that we make sure that we're providing that care at the same place that we can actually provide procedures. And then our Schaumburg location will truly be a medical hub. We'll have a little bit of surgical services there, but the focus is on the medical hub and relocating some of our services in our Huntley locations, as well as at our Northwest community location. And so with that and that additional space that's there, we really did an extensive reallocation process to make sure that we have the right services in the right locations as well too. And so this first slide is just a list of all of our outpatient centers across the region. And then I'll kind of go through each of those locations and some of the changes that are there and tell you updates on our Schaumburg and Austin location. So here are some updates to our Arlington Heights locations, Arlington Heights location with specialties and providers. Currently, we have removed the dermatology services from Arlington Heights, but we have increased provider availability with endocrine, genetics, genomics and metabolism, and hematology and oncology. So those will have increased provider availability at our Arlington Heights location. Our Grays Lake location, we had reallocation of our rheumatology services. They are now focused in Arlington Heights, Grays Lake, Skokie, and our Chicago main campus locations. We now have increased provider availability in cardiology, endocrinology, and urology at our Grays Lake location. Lake Forest orthopedics has been removed with a focus in all of those other locations that are listed there. Sleep medicine is no longer there, but still is at Grays Lake, Skokie, and Chicago. And then urology has been removed from Lake Forest, but has services at those locations. And we have increased provider availability of HEMONC at our Lake Forest location. New Lenox, we added on adolescent medicine with a physician as well as an advanced practice nurse. And we also have increased provider availability for cardiology, gastroenterology, hematology, and pediatric surgery at our New Lenox location. Northbrook, hematology oncology has been removed and still has availability at those locations. Rheumatology has been removed and sleep medicine has been removed, and we have increased provider availability of allergy and immunology and cardiology at Northbrook. Skokie, we've added rheumatology, cardiology, endocrinology, and urology services at our Skokie location. Westchester, as we were talking about, really driving more of the surgical services at our Westchester location, since we have procedural capabilities that are there. And with the new Schaumburg location, we have removed genetics, hematology, oncology, rheumatology, and kidney transplant. There's been a reduction, but still a presence of dermatology and endocrinology at those locations. And Dr. Wagner's clinic, since that requires the surgery capabilities to have there, will remain the same at our Westchester location. And then enhancements that we have had is to a lot of our surgical services, cardiology enhancements, ENT, gastroenterology, orthopedics, plastic surgery, and then urology. So increasing our surgical presence at our Westchester location as one of our surgical hubs. And then overall, at CDH, we've had some reduction of dermatology and urology. We have some brand new clinics that are there, which will be our urology circumcision clinic, our Botox clinic, which is in conjunction with the for the Marion Joy patients, and then increased provider availability for endocrinology, nephrology, and neurology at CDH. So then our exciting new location that will be opening in the fall of 2025 is our Schaumburg location, which will truly be a medical hub as well as an ambulatory infusion center. So that will be our first infusion center that is in an ambulatory location. So it will include a blood bank and a pharmacy as well. And the latest, we have a drone that's there that's flying. So all of the exterior is all up, and they're actually already working on the interior. I need to make my way there to take a look at it. Last time I was there, we were just breaking ground, and in a short period of time, all of the walls are up in the location. And as I stated, it's truly going to be a medical hub. So the subspecialty services that will be offered there are allergy, immunology, cardiology, dermatology, endocrinology, ENT, genetics, GI, hematology, oncology, neurology, pulmonary medicine, rheumatology, sleep medicine, a little bit of neurosurgery, ophthalmology, orthopedic surgery, pediatric surgery, plastic surgery, and urology. The services provided there, like I said, will be the ambulatory infusion center, as well as audiology and speech pathology, behavioral health, orthotics. We'll be able to do stress tests there, ultrasounds, and x-rays at that location, truly as functioning as a medical hub with the diagnostic services that are associated with those subspecialty services will be available on site and at that location once it is open. And then our second site that will be opening, hopefully in the springtime of 2026, is really a community-based partnership that we have done in collaboration between Stone CDC, really to serve the Austin community. So the services that are provided there are really focused on what the Austin community needs in their area, and that was how we actually decided on what specialty services would be there. The Lurie Children's Clinical Services will be located on the second floor of that location. The first floor will be the Lurie Children's Magoon Institute for Health, which will have education, training, and programming for the community, as well as have some gathering spaces on that first floor. And the second floor will actually be the Lurie Children's Clinical Services with a focus on behavioral health with group therapy rooms, pediatric chronic health conditions, adolescent medicine, high-risk asthma, weight management, sickle cell and kidney disease, as well as autism at that location. And then the third floor at the location will be the Thresholds West Side community-based outreach teams that are there. So really a focus on serving the community that's there right within their community and being able to provide those services at that location. Those are the exciting things I have. I am happy to take any questions as we have still, it looks like 6 more minutes of time.
Yeah. Great stuff, Carrie. So the infusion center, people are super excited about at Schaumburg. So thank you for bringing that up. I know it wasn't on the slide, but we get a lot of questions on that. So yeah, I don't have any more than I just know people are excited about it. So thank you for including that.
Well, I think for an ease of, families, the patient populations that are followed there need frequent appointments, and coming to the main hospital is a challenge when you're coming that frequently. So I think, this is the right thing to do, is provide those type of services in a safe and effective way that we can in a satellite location.
Yeah. Will the Schaumburg or Austin have immediate care?
Not at this time, they will not. It is something that we have talked about, our immediate care locations, but not at this time. They will not have immediate care.
Yeah, and as most of you know at this point, we have a partnership with PM Pediatrics for immediate care. So if you have questions about that, feel free to reach out to me or the other liaisons, and we'd be happy to talk to you about that partnership.
Mhm.
You know, the other question, you know, I cover the Northwest area, so Arlington Heights area, and I actually live here in Arlington Heights. And the big question I get on a regular basis is, Carrie, what's going to happen with Arlington Heights once once Schaumburg is up and running? Is that a partnership we still continue to look at doing, or we just don't have the answers to that yet because there's a lot of other things involved?
Yeah, I think that, a key thing is we want to see what services, what our Schaumburg location is. We've really allowed for growth within that location as well. So when we put those specialty services in there, we have an opportunity within that building to continue to grow, to serve the needs of the referrals in that area. So I think we have to see, where the needs actually are and where are the best locations to provide those so that there's ease for families to be able to get there. So I think we'll have to evaluate Arlington Heights at that point in time and really look at, that location and what the referral patterns look like to make sure that we're actually providing the care in that location that's actually needed in that area as well, too.
Okay, excellent. Thank you for pointing that out. I don't see any more questions on here, but I will say that this was really important information to share. I know a lot of people were eager to know what was going on with some of our locations. So feel free to reach out to us if you have any questions regarding the outpatient centers. Carrie, thank you so much for joining us.
Yeah, thanks for having me.
You have a wonderful day.
Thanks.
All right, we're going to continue on with the program. And my good friend and colleague, Paula Nowak, is next. Paula is going to talk to you a little bit about some of the new physicians that have joined Lurie Children's. I want to point out that Paula Nowak has been part of the Lurie Children's system for well over 20 years. She has a clinical background, but she really loves working with all you folks in the city, the south suburbs, in Indiana. She gets around. She really loves working with you all. Her passion comes out every single day. And Paula, thank you for presenting our new providers. And I'll go ahead and switch the slides for you. And again, thanks for joining us.
Yeah, thank you, Chad. Yeah, so we have a new CVT surgeon, Dr. Allison Davila, and she comes to us from Boston Children's Hospital. She's thrilled to join Lurie Children's. She grew up in Central Illinois. She's happy to be back and did her medical school at Northwestern. She specializes in neonatal and has done some fetal intervention. So we're really excited to have her join Dr. David Winlaw, our head of surgery, cardiac surgery. And we also have, not new to Lurie, Dr. Alex Jakovic, but new to New Lenox. Dr. Jakovic is a minimally invasive surgery specialist. He has advanced training in transplant, oncology, endosurgery, and ultrasonography. And in addition to his twice-a-month clinics in New Lenox, he is also going to be rounding weekly in the NICU and will be the primary lead pediatric surgeon. So any of you that have patients in New Lenox, if you have any issues with pediatric surgery patients in New Lenox, he will be your primary contact. And as you heard Carrie say, we have a lot of new availability of specialists in our outreach sites and downtown. And you can see a lot of them are in areas that you have been wanting more access. So allergy, we have 3 new cardiologists, a new psychiatrist, a new GI, 2 new hematologists, a nephrologist, and a neurologist. And you can see that they are at many different locations and have started there already. We also want to highlight endocrinology, knowing this is a great area where you've expressed need. And you can see some of these endocrinologists have started and geneticists have to start at the locations that you see, and others will be starting at some locations in the near future. So take a look, and then you'll want to be checking our specialist and location schedules that we present monthly for you. I think this is our most popular area from our physician services website, is those of you that check to look for the schedules at all of the outpatient locations. And they have a new look, so you can see how it looks. It's a cleaner look. We had a lot of information on there that seemed like it was just bogging things down. So we heard you. And again, this is one of the most popular things that the community looks at to see what's available in my area for my patients. And you can go to the physician services website to find these schedules and other referral materials. And I think Chad will be highlighting also the referral toolkit.
Yeah, thanks, Paula. So I'm going to go back to this real quick. With the schedules, each location has their own specific location, and they are readily available for you to download on our physician services website. I know many of you now are using that on a regular basis. We highly encourage you to go ahead and scan the QR code here now for anybody who is online with us now or watching this video. Please bookmark this page. Is going to make your lives so much easier, especially you referral coordinators and practice managers out there. All the information is right there for you. All the schedules that Paula talked about, our referral specialist guide is on there. Quick reference phone numbers, all of our services at locations, patient referral forms, lab recs. We even have all the videos of these great symposiums or roundtables around there. Please use it. It's there for you. However, it's not going to take the place of anything printed. We're still going to print these and deliver them to you. We plan on having them updated late in the spring, maybe early summer of 2025. And you'll have a package mailed to you. And of course, Julie, Paula, and I will deliver them by hand to you as well. And if you need extras, please don't hesitate to ask. But please take advantage of this. This is here for you. Julie, I want to bring in Julie Kalkbrenner. Julie, how are you? Good to see you. And Julie has been with us for well over 20 years as well as a liaison. She serves the West Suburbs, and she is very passionate about bringing the information to you guys as well. And Julia was actually on the committee to help bring in Lurie MD. So she's a perfect person to come here and talk about Lurie MD. Julie, go ahead.
Thank you, Chad. So as a reminder, we have the 800 number for Lurie MD. It's a provider-to-provider reference number. So it really is an opportunity to connect the community provider with a specialist at Lurie. If you have a question on whether or not to send a patient in for a referral, ED consult, direct admit, our attendings are ready to answer the call. The phone line is also used by some of our fellows too. So it's very easy, but it really is intended for a provider to provider type of conversation to continue patient care. So hopefully you all are aware of this and have had a chance to use it. It's something we are very proud to offer to our community providers.
Yeah, thanks, Julie. And can we note that if you have an experience that you really enjoyed with Lurie MD or not so much, please let us know, because your feedback really helps us improve the Lurie MD line.
And we also have a couple of online resources available to our community providers and families for mental health. The first one is RAMP, the RAMP program, which is Resources for Advancing Mental Health in Pediatrics. So this really is an online tool for providers and for patients and patient families to give extended information and helpful, tangible information for diagnoses and conditions, something for referencing anxiety, ADHD, tics, disorders, autism, substance use, and also eating disorders, along with a variety of other diagnoses as well. But this RAMP Hub actually has a curriculum for providers to follow, which is small modules, so they're easy to follow and kind of can work with your schedule. We also have patient education and videos for families and patients to reference as well. One of our newer resources is Children's Little Ones. This is an app, so no website here, but just really quick, easy app. It's for geared more toward for families of toddlers and preschool age. So really kind of a resource for parents and really any caregivers, such as daycare providers, grandparents, to have some quick reference on how to handle some of those more common preschool toddler issues that come up, like anxiety, hyperactivity, and also disruptive behavior. So this is new. This app will continue to add more information as time goes on, but it's something that was developed by one of our social workers at Lurie, along with Dr. Miller Shivers. So it's a great resource for parents and families to tune into. Just wanted to share that with you.
And it's free.
And it's free.
It's
Yes,
free. Download it.
it's
It's free. Hey, on the RAMP website, Julie, folks are able to download resources as well, correct? So they can
Absolutely.
download the PDFs to their desktop, print them out if they need to, correct?
Absolutely. Thank you for bringing that up. Yes.
Yeah,
Easy
you're welcome.
access to information.
I mean, it's great material. As a parent, I like to read them myself. So I highly recommend all of you listening or watching the video. Please go to the RAMP website. It's going to help you. It's going to help your patients. It's going to help their patient families. It's just a wonderful, wonderful resource.
Yeah, I agree, Chad. I've heard a lot of pediatricians and pediatric providers comment on how much they love the handouts for parenting children that have mental health issues.
And we do try to give a little snippet of some of the resources in our monthly e-newsletter just to keep you abreast of what we have on there and how it may be helpful to you and your patient families.
I'm glad you brought that up because I was going to mention Julie helps put together this newsletter that you all receive, and the RAMP is one of the most highly clicked parts of our newsletter. So once you get our newsletter, read it, go to the RAMP page, it'll click in and take you right there. So and read our newsletters. They're very beneficial for you. Julie, what about your coding seminar that's coming up? Tell us a little bit about that.
Yes, this group is the first to hear. We have our annual pediatric coding conference set for Friday, February 28th. It will be in Oak Brook. Dr. Linda Parsi will be speaking for us again this year. I believe this will be her third year with us. So we're really happy to have her back. She is a private pediatrician in the San Antonio area, and she also works on the AAP coding and nomenclature board to help make coding easy for all pediatricians. We have some of our agenda picked out as well. So she'll be doing updates for telehealth. We discussed telehealth today. So she said there will be a lot of changes that will be rolling out in 2025 for telehealth, as well as the overall ICD-10 updates for 2025. She'll be referencing using medical decision-making for coding strategies. And then best practices for mental health coding, how to code best for obesity, and practical tips to conduct and prepare for an audit, whether it's an outside audit or you're going to be doing that internally in your office. But registration will open early January, and you will be receiving notification on that once we have CME and our location all buttoned up. So thank you for your interest in our seminars.
Yeah, it's centrally located too, so easy for everybody in our region to get to. Right off the highway, so it'll be great. So, yeah, that's excellent. Thank you, Julie.
Thank you.
So, I know we are running a little over here, folks, so I really appreciate you staying with us. We have a Q&A session open here, but I don't see any new questions here, so I'm going to go ahead and continue with the program and end the program. But if you have questions, please type them in. I want to remind you all that I know you receive emails from us. I know you get communications from us. We try to limit them because I know you get so much email. But if you are craving more information about our services, follow us on social media. We have a great Twitter page that we keep up, our LinkedIn page, and we have a Facebook page for most of your patients are on that. But we also have a YouTube page, and I think you'll find that page extremely useful because we do keep all of our roundtables and our virtual sessions just like this on there for you to reference when you need to, or when you get a new provider into your practice, you can share that with them so they can see the information as well. But I just wanted to thank you all for joining us today. Your participation and our speakers, and I want to thank all of our speakers for their valuable insights. As you return to your important work, remember to stay connected with us. Reach out with questions. Again, please bookmark the URL. It's going to make your job so much easier for easy access to referral information and resources. Remember, together, we're creating a healthy future for our children and families. And thank you. And let's continue this vital work together. Have a great day, everybody. Julie, Paula, thank you for joining me today. Have a great one, everybody.